Good morning, everyone, and welcome to today's Medical Grand Rounds. We're so delighted to have you here. I will begin with just a few reminders and announcements and then introduce our speaker for today. So next week, I'm so excited, we'll be hearing from Dr. Nathan Svanix. He is our current chief resident for the internal medicine program here at St. Vincent. And Dr. Svanix will be here presenting live in Southern Auditorium at Providence St. Vincent. So please be sure to join us in person, or if you can't, we will be here as well on Teams Live. And just a reminder about that this Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland. Grand Rounds is always available on this Teams Live platform, and we will keep you posted as in-person viewership is available. That is always noted in the invite for Grand Rounds each week. And you can earn CME credit for any way you choose to attend, whether it's in person, live virtual, or also by watching a recording of the session. And that recording is available at the same link as the invite for Grand Rounds. I'll be monitoring the Q&A throughout the session today, so please go ahead and put in any questions or any comments you have, and I will mostly hold those until the end as time permits. And now finally, to introduce today's speaker. We are joined by Dr. Sean Stanley, who is an outpatient psychiatrist at the Oregon Health and Sciences University with an interest in medical education, professional identity formation, and providing rational, effective treatment for diverse psychiatric outpatients. Dr. Stanley is an assistant program director for the OHSU Adult Psychiatry Residency, co-chair of the OHSU Psychiatry Grand Round Series, and the incoming chair of the OHSU Medical School Admissions Committee. Dr. Stanley, thanks for your generosity in teaching, as always, and we're so glad to have you with us today.
Yeah, thanks, Dr. Lucha. I really appreciate your invitation, and I'm excited to talk about the topic today. This is a presentation that I also gave to the Oregon chapter of the American College of Physicians, and so I'm excited to re-give this, hone it a little bit. I'm going to talk a little bit about adult ADHD today, which I imagine many people are seeing. We'll talk a little bit about attention in general, and then focus down on what is ADHD, when you might be suspicious of ADHD, and how you might treat it if it truly is ADHD. I have no financial conflicts of interest. I will be talking about a couple of medications used off-label for ADHD, but they do have a little evidence for its treatment. But I really am going to only talk about that briefly. We're all drinking our coffee this morning, so we should all be somewhat familiar with stimulant medications or treatments for attention. And we'll talk a little bit more about truly diagnosable psychiatric inattention and how we treat that. So our objective is really identify the various reasons for inattention in adults. Oops, sorry about that. And why it's important to assess for these. Outline the basic approach to and the simple tools to determine if an adult has the neurodevelopmental disorder. Note I said neurodevelopmental disorder of attention deficit hyperactivity disorder. And then look at some of the differences between common ADHD treatments and adults. This presentation is geared a little bit to stimulate your mind and actually have you try to answer some questions so that we can then compare your answers to what the evidence says. Is there an agreed upon definition? Sorry, goodness gracious, keep touching buttons. Is there an agreed upon definition, a quantitative definition of attention? Is there an agreed upon quantitative definition of attention? There is not. We do have a construct about attention. So attention is defined by the American Psychological Association as a state in which resources, so cognitive resources, are focused on certain aspects of the environment rather than others. So, selectivity and where those resources are going, as well as the central nervous system is in a state of readiness to respond to stimuli. So the central nervous system is ready to respond. So got resources focused and ready to respond. These are the two aspects of attention. Sometimes different situations or settings require one more than the other. So a receptive attention, an expectant attention versus a focused or activated attention. Second question, can humans have perfect attention to their environment? I hope you probably recognize that they cannot at this point. Here's a fun fact. So in the year 1500, the amount of time that it took for a person to consume 75 gigabytes of data, 1500, was one lifetime. information came fairly slowly at that point. 75 gigabytes of data in 1500 took one lifetime. But in 2020, it only takes 1 day for someone to consume that amount of data in their environment. So the informational environment has changed substantively. But in addition to that change in the informational environment, there's a huge attentional bottleneck in what our brains can actually process or be conscious of. The number of bits of information the brain can perceive in a second is 11 million, although the number of bits of information the brain can actually be conscious of is only 60 to 120 per second. So that's about 1/1000th, if I did my calculations earlier correctly. The brain can only be conscious of 1/1000th of the information that the brain is actually perceiving. Again, that's what's incoming versus being conscious of. So only a very, very small amount of that information can we be conscious of or have attention to. So are there different types of attention? We talked a little bit about this kind of expectant attention versus an activated attention. And yes, there are different types of attention. As you can imagine, if you're daydreaming in a field watching the clouds, you do have attention going on, but that attention is going to be slightly different than if you're a trauma surgeon who's having to manage a highly chaotic situation with high import. It's going to take a very different type of attention. So we're going to step through this diagram, which we'll go back to a couple times, but this is an important understanding of different types of attentions. So the first type of attention we're going to talk about is focused attention. So this is where, an individual focuses for a brief period of time, and then we'll refocus again and focus again, but maybe on the same thing. So it is considered arousing. So it's kind of, okay, wait, something has come up in my environment, I'm going to focus on it. Or alerting, you can think of this as, people who may have, delirium or other impaired consciousness may have impairments in focused attention. They can't even bring their brain to attend on something specific. So this is the lowest level of attention. Above that is sustained attention. So it's not just focusing, but it's actually focusing and holding on that an individual task or stimulus for a while, holding and maintaining. So as opposed to just focusing briefly, it's focusing for a while, staying sustained. And then selective attention. Okay, there's a couple things that come up. How can I choose what I'm focusing on and filter out the rest of it and maintain my selective attention on the thing that I really need to be focusing on in this case? So again, more complicated than just focused or sustained attention is selective attention, making that selection and holding on to that. Even more complicated than that is alternating attention. So it's being able to both be selective, but be able to flex and maintain some background awareness of when one needs to choose what they're attending to specifically. So it's selective, but it is also continuing to be activated, aware, so that one can change and alternate attention when needed. And the last attention, which some people feel is not even in existence, that humans can't even honestly do, is divided attention, where they're attending to multiple things equally at the same time. So maintaining focused attention on multiple things at the same time. These different types of attention do vary in different ways. So from the most basic is really a point focus, less background awareness, really more bottom up kind of arousal type attention. And it requires fewer neural resources and really relies mostly on subcortical regions of the brain rather than cortical executive function areas of the brain. And as we increase in this complexity of attention, we see that it requires more point and field focus. So focus on the specific thing, but also awareness of the background field. More top-down filtering, more inhibition, selection, and switching required, and therefore it requires greater neural resources and uses more areas of the brain, more cortical, in addition to the subcortical regions of the brain. So you can imagine that this is divided attention is something that we're going to exhaust. If we're doing it, it's going to tire us out quite a bit, or it's going to require a lot more resources to do. I use this diagram just to show that there are multiple areas of the brain that are involved in attention. Certainly these areas in, before the central sulcus and but you can see how they're also distributed over multiple different areas of the brain. So different areas of the brain will be involved, and therefore you can see lesions in different areas of the brain having effects on attention as well. Skip that one for now. Does dopamine drive attention? And this is one of the things that I think a lot of people think, and yes and no. So dopamine is involved in attention, but it may not be the sole driver of attention. If you've not seen this inverse U-shaped curve before, this is something that you'll probably see come up over and over again, and it does well describe how people's attention varies over a diversity of catecholamine or dopamine states. So at low catecholamine or dopamine states, people have poor attention. You want a middle range of catecholamine or dopamine states, and that provides optimal focus and awareness. But if you increase that too much and increase the dopamine, you're going to overfocus and really become so fixated on things that you may not have a functional degree of attention either. The ventral tegmental area is really the area that drives dopamine availability in different areas of the brain, and signals to the prefrontal cortex, signals to the hippocampus, the nucleus accumbens, the amygdala. So lots of different areas are under the control of dopamine release from the ventral tegmental area. And you can see if the ventral tegmental area releases more dopamine, people might go up on this curve. If they're already at a higher level of this curve, they might go over the curve. So stress states, anxiety, panic, tachycardia, I mean, all these things are driven by elevated catecholamine states. But if the ventral tegmental area is really at a reduction, is not releasing, or there's another reason why there may be less dopamine available, you'll see people at the lower end of this. Maybe relaxation allows people to take the foot off the pedal a little bit. But also it can lead to less focus, more impulsivity, because they're not able to manage their decision making, substance use with the intent to increase that dopamine. So this is just an important curve to recognize, and we'll see as some of the treatments may move people up on that curve or may move people back down on the curve. But again, dopamine is not the only player. Acetylcholine is also involved. There may be other neurotransmitters, GABA as well, that are involved in attentional states. So dopamine is one of the ways we really modulate people's attention, but acetylcholine, GABA are likely involved as well. Is there an agreed upon quantitative definition of inattention? Just like attention, not really. We don't have a quantitative definition of inattention. But we do have a construct that guides us a little bit. So as again defined by the American Psychological Association, inattention is a state in which there's a lack of concentrated or focused attention, or in which attention drifts back and forth. So again, just giving a sense that attention is not there. How are we defining attention? I think it's important to remember that inattention may not always be problematic. We're not always needing, always in our life, to be perfectly attentive. Dreamers, poets, composers, all sorts of types of people may get in states of reverie and where their attention is drifting, and that may actually be helpful in some of their work at times. And also just to relax and sleep and things like that, we need to not be attentive. It would be hard to be attentive all the time and to be able to get rest at the same time. But we do know that in most of our environments, we do require some degree of flexibility and responsivity to those environmental requirements in order to maintain functional attention. Again, the attention required to have, be watching clouds and identifying the animals in the clouds going over your head might be slightly different in terms of the resources or the types of parts of the brain that are being used, as opposed to this really highly engaged, either alternating or divided attention in a high acuity situation. So we're not going to need all of these, every job might not call for all of these different types of attention, but what we do want is to be able to flex and be responsive when an environment requires. Now, in dysfunctional attention is when the brain cannot be flexible and can't respond to those environmental requirements. So again, if someone is hypo-aroused, they're altered consciousness, they're not going to be able to get focused or sustained attention. Or people who truly have some metabolic issue, or may have depression, or may have ADHD, may not be able to get to selective or alternating or divided attention because they may be their cognitive the faculties are going to be impaired to the degree they won't be able to do that. I think we all have limits. This is a great photography series by Powell Cass. If you haven't seen it, you can look it up. It's called Crowded Fields, but it really is a commentary on really if we were attending to the complexity in our world, how much we'd have to attend to. Imagine being the judge at this particular match of, 40 tennis players against another 40 tennis players. It's impossible. There are limits to our function. But for most people, dysfunctional attention really consistently fails to modulate those cognitive resources, at least in terms of adaptation to a low average or age appropriate environmental requirements. We're not going to ask a kid to attend to a trauma surgeon's level of focus. And we're not going to expect that everyone is going to be able to have a trauma surgeon's level ability to focus. But what we do expect for most adults is to have at least the ability to have selective attention. So that's, again, to be able to filter out a little bit, focus on a specific thing, and maintain that focus for a period of time. Even if that's, making sure to not be overstimulated by the cell phone ringing or the kids in the background and focus on doing some emails or finishing up that charting. That's what we expect, is some selective attention. We also, in many situations, will expect some alternating attention, going from one thing to another, and then maybe less commonly, if at all, really truly divided attention. So really, we're looking, can people be selectively attentive? And if they can't, then they probably are at a problematic level of attention. Is ADHD the most common cause of dysfunctional attention presentations in primary care clinics? What do you think? Yes, no? I gave you a false question, really. We don't actually know. Given the number of different presentations or number of different causes for attentional problems, it's low likelihood that most adults coming to a primary care clinic are going to actually have ADHD at the heart of their attentional problems. There might be some, but again, there's lots of other causes that are likely more common in adults. So toxic metabolic causes, certainly iron deficiencies, electrolyte abnormalities, significant renal or hepatic disease, infections, blood sugar problems, all more likely to contribute to attentional problems. Thyroid disease, fatigue due to a number of different sleep disorders. Any impaired sleep is going to likely very much impact attentional states during the daytime. They've actually done studies with kids diagnosed with ADHD and found that a significant number of them do have sleep disorders. And actually, it's becoming a very, very important thing to screen for, not just in adults where it's more common, but even in kids. Neuronal disease, multiple sclerosis, stroke, seizures, anything that's going to, again, impact those areas of attentional selection or attentional awareness are going to have impacts on attention. Multiple psychiatric diseases have inattention as part of the cognitive profile associated with those diagnoses. Major depressive disorder, anxiety disorders, both very commonly have inattention associated with them. PTSD, bipolar disorder, psychotic disorders, other learning disorders. So sometimes people have inattention because they just can't read, or math is incredibly hard for them, and that causes their inattention problems. It's much better to diagnose those specific learning disorders rather than a global ADHD, although they commonly do run together for many people. Really important to also be aware, visual and hearing impairments are really important to identify because they're actually quite common causes of attentional challenges. Addiction or substance use. We'll talk a little bit more about cannabis use, but alcohol, internet addiction, other highly, highly stimulating things that are going to force our brains into a pattern of dysfunctional attention, meaning inattention for the other things that they need to be able to attend to. Lots of different medications are involved in inattention. Also environmental factors, which I think is really interesting and important to remember. There are people who have attentional problems because they have a skill mismatch to what they're being asked to do. People who have gotten into the wrong job for them and their brain just doesn't do very well with that. Vocational disinterest, lack of prioritization, distraction, change. All these things are environmentally modulatable things. We often do talk with our patients about whether part of what the challenge in their attention at their work or home is, they just don't feel interested in it or motivated to do it. And that may not be an underlying neurodevelopmental disorder, but that may call for some change in what they do. I've expanded on that last chart just to add some additional, testing or exam that can be helpful in discerning these things. I won't go into this significantly, as you all as medicine providers probably have a great idea, probably better than I, how you evaluate most of those things. This is a slide that I think a lot of people find helpful is, if you have depression and inattentional problems, or depression and ADHD, what do you treat first? In almost every case, you should treat the non-ADHD thing first, the other condition first. So substance use disorders, of course, you're going to treat the substance use disorder first, get that out of the way, see if ADHD is left. The only caveats for that are in moderate or mild major depressive disorder, or moderate or mild anxiety, where you might actually have to see, objectively and subjectively, is their attention challenge actually the major cause to why they're having troubles in their life, causing them having depression or causing them anxiety? In some patients, it can be very clear that their attentional challenges are really at the heart of most of the dysfunction, and really the depression and anxiety are secondary to the attentional challenges. So if I see somebody who's got mild or moderate depression and screams to me objectively in the office or in their history, if you do a life history and you hear about all their challenges in childhood and early adulthood, with work, relationships, attention, substance use, all sorts of different things that they might have gotten into, you might kind of a little light bulb may go on your head that maybe this is a ADHD first, and that's what's causing their challenge. But you'd want to do, of course, more evaluation. But those are the only conditions where I think ADHD is really the thing that you're going to want to consider treating first. And in all the other conditions, you treat the other condition first. Do patients usually accurately self-report substance use in clinical settings? Gosh, great question. What do you think? Answer is actually yes and no. Again, interestingly, it depends on what patients want. If they're coming in wanting medications or a diagnosis, odds are their self-report is less accurate. So here's a study that showed that self-report in primary care was actually of substance use. So these three substances, opioids, cannabis, and amphetamines, was actually significantly lower than when you tested their urine for the substance. So about half of patients reported their opioid use. A much smaller percentage reported their cannabis use, and none of them reported their amphetamine use, although that was really overall a small percentage of the population that was using. So significant underreporting of substance use in most primary care clinics. The only exception to that is if someone's coming in actually wanting to get help for their substance use. Again, it depends on what they want. If they're coming for getting help with the substance use, they're much more likely to accurately self-report. If they're coming for some other a desired diagnosis or desired medication, likelihood that they're going to underreport, unfortunately. So this is a big question. Can use of cannabis once a week affect attention? The evidence says yes, even once a week. The health effects of cannabis and cannabinoids report by the National Academy actually had lots of great evidence. It's a huge report, but they had when they looked through all the evidence, they did find moderately strong evidence that cannabis use is associated with increased risk of learning, memory, attention in acute use. So this is acute use of that will cause problems. Part of the reason why that is likely, remember that dopamine curve, is when you use cannabis, you're depleting your dopamine stores, depleting the dopamine stores, and you see a deficit in dopamine release from the striatum. So you're not actually getting the dopamine release you need. So if you're looking at that curve, it's actually the cannabis is pushing people much further down on that curve, so more in an inattentive state, a low dopamine state. So that's what cannabis is doing. If you need to have conversations with patients, I give people these two reports quite frequently. They are, reader-friendly, patient-friendly reports, but they do a nice summary of the evidence about the effects of cannabis on the brain, including on cognitive function. The second one, which is from Canada, actually has a much more specific focus on cognitive functioning, where the first one is really a more general one. So let's take a quick recap here. So attention and inattention are states of balance of cognitive resources to environmental demand. Again, what you're bringing cognitively resources to what the environment is demanding. There are 5 levels of attention, from low demand to high demand: focused attention, so that's even just arousing; sustained, selective, alternating one to the other, and divided, where you're actually able to attend to multiple things at the same time. Perfect attention is not at all possible, but selective attention should be expectable for most adults. There are many non-ADHD causes for inattention, important to remember. We're going to issue our big break, quick break to go on to our next topics. So is the criteria for ADHD diagnosis in adults different than for kids? Actually, yes, it is. So it is different in that you need less number of symptoms in either category to diagnose ADHD. So in an adult, the DSM-5 criteria are divided into 9 different inattention symptoms or 9 different hyperactive impulsive symptoms. If you were a kid, you need to have at least 6 in either one of these to be able to meet the criteria for ADHD. But in adults, it's only 5. And there's a couple reasons why that is. Really, it partly has to do with most well-functioning or most adults will have over time made some adaptations to milder attention or hyperactivity problems. So, odds are they've, done a little bit to try to help out that, help reduce their symptoms. So really a lower symptom a number is probably more expectable for people still having dysfunction. They've also gravitated to areas of strength. So they're not a kid who's being forced to sit in their chair all day long. They probably have been able to choose and find some environments where they're better functioning in. But if they're still having those symptoms, even in those environments where they have better function, it may not take as many of those symptoms to cause dysfunction. The other challenge for adults is that adult life has a lot less tolerance for variation or growth. We don't give adults leeway much at all, while we give kids a lot of leeway. And therefore, poor function in adults also has a lot more risky or severe outcomes. So having 5 symptoms of ADHD may still lead to a lot worse outcomes for adults than having 9 symptoms would have for a kid. As you can see, over the course of people's lives, societal expectations increase. So as you're going from preschool, there's not a heck of a lot of expectations at that point. School age, a little bit more. Adolescence, some more expectations. But once you get to college and adulthood, those societal expectations increase significantly. As well as risks, the dangerous temptations increase. Luckily, during preschool, the most dangerous temptation you have is maybe to, eat chalk or run in the street, which are problematic, but there's a lot more temptations in college age or adulthood when people are having to self-manage. So the idea is that the risk of untreated ADHD is a lot higher in adults than it would be in kids, where we have a little bit more tolerance and there's a little bit more safety and more structure for most kids. So to be diagnosed as ADHD in adulthood, you have to have ADHD symptoms as a child. I forgot to mention, let me go back a couple steps. This highlighted box here in the DSM-5 criteria is that you have also, in order to have ADHD as an adult, not just 5 symptoms in either of these categories longer than 6 months, but you also have had to have those symptoms at an age less than or equal to 12 years old and noticeable in multiple settings. So not just in school, but at home, at church, playing with friends. That's noticeable even from a young age. So yes, you have had to have ADHD symptoms as a child to be diagnosed as ADHD in adulthood. It's a neurodevelopmental disorder, starts early. Maggie Sibley up the road in Seattle, I think she's still in Seattle, did some great studies with people who had identified that their ADHD symptoms came on in adulthood, and really did a deep dive into other conditions, other medical conditions, and essentially identified that there are really not any patients, maybe very rare, but really not any patients that really have their onset of true ADHD symptoms in adulthood if there's not another cause. Most other causes of inattention onset in adulthood have to do with other things, not purely ADHD. So they made a distinction between adult identified ADHD, that's somebody who had ADHD as a child, but really wasn't diagnosed until adulthood, versus adult onset. And we really think that there's not really much true adult onset ADHD when people didn't have it as a child, but it became present as an adult. Is ADHD a lifelong disorder that never changes? No, actually, there's really good studies that in young children, hyperactive and impulsive symptoms are higher, and then over the course of time, those diminish as people age. And really, the inattentive symptoms become more prominent, or a combined presentation become more prominent. As well, the percentage of people who kids who have ADHD is about 10 to 11%, but it reduces into adulthood. And so into adulthood, about 5% of patients have ADHD. So about half of those who initially would have been diagnosed as kids end up still having those symptoms to a dysfunctional degree in adulthood. The brain changes, thank goodness. Our brain matures over time. We develop skills. We find settings where our brain works. So really only about half of those kids who have ADHD, diagnosable ADHD in childhood, end up having dysfunctional ADHD as adults. We also do know it used to be that ADHD had types, so inattentive type or hyperactive impulsive type or combined type, but we actually, as tracking individuals over time, we found that their presentations differ based on different settings and different times of their lives. And so it's really, people can at one point have an inattentive presentation, later a hyperactive presentation, or a different environment or set of demands in a hyperactive impulsive presentation. So it's less types and more presentations. If ADHD starts early, is it a genetic-driven disorder? Oh my gosh, is it? Very interestingly, ADHD has one of the highest heritabilities of any psychiatric disorder. Hint, hint, if you're seeing a patient with ADHD, you're probably also likely that person is likely to have had either parents who had ADHD or children who have ADHD, which can be a challenging situation, right? You got to have some empathy or sympathy with a kid who has ADHD and attentional challenges, but also was raised by a parent who also struggled with attentional challenges. It may not help create the structure that kid needs. So highly heritable disease. So to diagnose ADHD as an adult, you have to know whether they had symptoms now and whether they had symptoms as a child. What do you think, yes or no? The answer is yes. So as a primary care provider, as a psychiatrist, it's not always easy to figure out whether somebody had symptoms as a child, especially since self-report on childhood symptoms is prone to error, both false negatives and false positives. People who have ADHD and say, actually, no, as a kid, I didn't have it, or patients who, but they're incorrect, or patients who said who don't have it, who said they had symptoms as a kid who didn't really have it. So there are both false negatives and false positives. So that recall, as we all know from many things, recall in our childhood is not always correct. So is there a guideline that can help us evaluate and treat ADHD? Is there a US guideline? There's actually not, unfortunately. And this is part of what's led, I think, to the challenge more recently in excess of stimulant prescriptions through electronic prescribers. In COVID-19, there's a really upwelling, obviously, of telehealth and accessibility to different care providers, but there are large concerns about the expansion of some of that and some of the decreased precision of those assessments prior to making ADHD diagnoses. See it in the Wall Street Journal, certainly concerned that stimulant drugs were overprescribed, and there's really a call for guidelines. There's no US guideline. There's a group of folks, Maggie Sibley, who I mentioned early, up at UW, who had done the research on whether there truly was an adult onset ADHD, is actually part of this group. But this is a group of highly qualified psychiatrists, clinicians, psychologists, researchers who are all involved in trying to create a guideline for adults with ADHD to help out in the US. There are guidelines in Canada, which I use, the CADRA guidelines, and quite frequently. I think they're very helpful. It may not apply perfectly to our system. They have a slightly different system of assessment and support for patients with mental health disorders, a more well-integrated system than we might in many ways. But I think the practice guidelines, the assessment guidelines, and general practice guidelines are quite good with the CADRA guidelines. Here's what they would recommend. They recommend the assessment of current function. Okay, so we want to see if somebody's got symptoms now. So using something like the ASRS, as well as an assessment of their function at age 12 or less. They recommend something like the SNAP 426 item, where you call a parent or call an aunt or teacher, somebody who knew them as a child very well, who would be able to report on back when they were 12 or less, were they experiencing these symptoms? So you're getting both a present and an age less than 12 assessment of the symptoms. Even more than that, you also want to get a longitudinal functional family history to get a sense of kind of what were there other things going on? Were there, reading problems? Was there trauma in this family? Was this kid abused? Is there substance use in their history or even going on right now that will also inform you on other risks, certainly. Now, I find that this particular order of assessment is problematic. And I switch it around a little bit, partly for the reason that if you ask these questions first, more and more patients will be able to say, okay, well, this is what they're asking for. So I'm also in my history going to go ahead and put these questions, my dysfunction in the forefront, which, may actually be true, but I feel like it prompts patients a little bit too much. So practically what I do is actually get a longitudinal functional or family history first, understanding kind of what their life was like in school as they aged. How was school for them? How was friendships? What kind of things did they enjoy? Did they get into challenges in adolescent years? Or how was college for them? Or what did they do after college? How has having jobs been? How has relationships been? Am I seeing any of these things come up in their longitudinal and family history? And if I do see a pretty consistent pattern of those things, I might say, shoot, this is somebody I probably do want to assess for ADHD, and then I'm going to ask them to do an ASRS, and then I'm going to ask them to get a given ROI so I can talk to somebody and fill out the SNAP 426 item. If all of these things check out, gosh, if this, their longitudinal functional history seems like it squares with ADHD, typical ADHD life progression, and they are still expressing enough symptoms to meet the DSM-5 criteria now, and I ask collateral, and they certainly did have that, and I've had multiple experiences of talking to a family member who says, oh my gosh, I noticed all these things when they were kids. They were just so active, they couldn't attend, they had such trouble at school, we had such struggles at home trying to get them to do their homework. It's very clear that many family members that recall do remember a whole lot. It can give you a very adequate picture of somebody who is struggling. Sometimes they don't. And also, I think sometimes it's challenging because sometimes a family report may also be colored by their own perceptions, values, and things like that. So sometimes you do have to take that with a little grain of salt. But I feel like if you have all three of these things in alignment, you're pretty squared away for an ADHD diagnosis if there's no other medical condition playing a role. So I'm going to recap to here real quick. ADHD is very genetically driven and heritable. Adult ADHD is a neurodevelopmental disorder with dysfunctional symptoms present beginning in age 12 or younger, although symptoms can shift over time. The DSM-5 criteria for adults requires 5 or more symptoms in either cluster to meet symptom criteria. Again, a little bit less because the consequences are a little bit more. A social history of multi-setting dysfunction and collateral report of childhood and attention hyperactivity dysfunction are better predictors of ADHD than self-report. So again, getting that evidence of multi-setting dysfunction from a young age and a collateral report from a adequate historian of when that person was a child is better than a self-report. And there's no current U.S. diagnostic or treatment guideline, but it could be on the way. So be on the lookout for that. Another quick break. Should treatments of ADHD in adults start with medications? The answer is no for that. There may be times in our system encourages that or patients desire that, but I think it's important to be able to pull back a little bit and talk about the diagnosis and to encourage some behavioral change before going down the road of medications. So first of all, instilling hope. There are a lot of successful people who have ADHD out there. There's no doubt about it. It's also to express understanding of the challenges and frustrations, empathize with what they've experienced, express the desire to help. Explaining the core symptoms, that there are mood and sleep changes associated with ADHD, and adequate treatment rationale is important. Also being aware of cultural, ethnic, or gender issues and their shaping ADHD and treatment. We have a great slide in another presentation that shows the flip side of the vulnerabilities in ADHD. So somebody who may be impulsive may also be spontaneous. Somebody who's going to not be able to hold their focus a long time is going to come up with new ideas all the time. So there's a plus and minus to all these ADHD symptoms. And so you want to be able to help the patient identify strengths as well as some of the plus sides to some of the way their brain works, to not side with demonizing the way their brain works, just saying it doesn't work as well as you want it to in certain situations, and let's think about how we can help you with that. You really want to encourage a balanced lifestyle, exercise, sleep hygiene, nutrition, relaxation. If they're not getting these things, then it's really important to do so, because you may not, any medication you use is not likely to be super helpful. There are lots of resources that can be helpful. I listed these here and give these to patients all the time. But do non-pharmacological treatments for ADHD actually work? The evidence is actually yes. There are a number of different interventions that people can use non-pharmacologically. You think about these things, many of us have these in school, and sometimes they go away after school, and we have to self-manage. So structure, attainable goals, prioritizing, visual reminders, timers, white noise, you can filter out things, planning frequent breaks. There's a number of things that strategies that people can use at home. At work, in addition to those things, people can get workplace accommodations, different places to settings to work, different ability to take breaks, regular meetings with the manager to help prioritization, set structure, short-term goals, time management strategies, interventions for decluttering, organizational apps, a whole lot of things that can be, again, helpful with organization prioritization, as well as executive function coaching, which we'll talk about here in a second. It's something we really refer a lot of medical professionals to. And then psychotherapy can be helpful. There's evidence for cognitive behavioral therapy and being better in conjunction with meds than just medications alone, and actually can be helpful for mild symptoms on their own without medication. CBT can be helpful without meds. And then mindfulness training. Both of these are helping the brain retrain to focus, filter out other things, and develop organizational strategies. The Cochrane Collaborative has looked at CBT as a treatment for ADHD and do find that it's better than placebo. The effect sizes are not huge overall, but it does show overall that CBT is associated with both clinician-reported improvement in ADHD symptoms and patient-reported improvement in ADHD symptoms. Generally, I find this more helpful for mild ADHD or in conjunction with medications for moderate or severe ADHD. There's clear evidence that CBT changes the way the brain functions, which is part of the reason that it's helpful for attention. Executive function coaching is kind of a new thing that's coming up, and it's kind of de rigueur right now. So it really involves, it's kind of like therapy, but it's more applied to specific skill sets. So really helping people develop self-regulation skills, also helping them develop organizational skills, and sometimes even taking that into the school environment or the work environment, where the coaches will actually go with the individual patient into their environment, help structure things for them, set up things in a different way. And a really high value a tool for a lot of people, especially if they're typically high functioning people anyway who are really struggling in a certain environment. Exercise for ADHD, huge. Something we don't talk about enough. Exercise is very impactful. Again, exercise increases catecholamines in the short term, and it's actually really helpful for focus, both for purposeful attention or selective attention, but also for awareness. So increases hit reaction time. So decreased time to hit when people are exercising with ADHD or exercising, and also decreased percentage of omissions. So they're more aware of things in the background and able to identify them. So exercise is actually quite helpful for ADHD. Do medications for ADHD universally increase dopamine? Actually, they don't universally increase dopamine. We're going to talk a little bit about these medications just in high-level terms to help understand them a little bit. The ADHD medications are generally broken down into stimulants or non-stimulants, although this distinction is really kind of a misnomer. What we think of as stimulants, or people talk about as stimulants, are generally medications that involve amphetamine or methylphenidate, two very different medications. And then there's lots of different preparations in either of these kind of families of medication. Amphetamines actually have a distinct mechanism from methylphenidate in that they increase the release of dopamine. So it's a dump of dopamine, norepinephrine, and serotonin all into the synapse very quickly. I kind of describe it as kind of barfing back up all of the dopamine, norepinephrine, and serotonin that the neuron has stored. So very quick dump, which kind of gives you a sense of why that euphoric effect can happen in some patients. They're not, One amphetamine version that I will mention, only because it's used more commonly in Europe. In most Western European or other countries around the world don't actually use immediate release amphetamine. It's often illegal in many countries, especially in Asia, but many do encourage extended release or sustained release versions of amphetamines, but only if people have, and only use immediate release if they've failed the extended release. And they don't use it as multiple doses ththrough the day. They use it as a single dose in the morning, assuming that that patient is a slow metabolizer, and that single dose in the morning is going to last them a long time. I bring up lisdexamfetamine, which is Vyvanse, because it has a slightly different, it's actually an amphetamine attached to a lysine, and when that gets into the red blood cells, it's actually hydrolyzed and separated. So it's much safer. It's slower onset, so people don't get this peak euphoric effect. It's sustained longer and a more even profile. So again, many European countries actually like Vyvanse and encourage that as a version of the medication. It's shown to be less abusable. You can inject it or alter it to have a euphoric high or abuse it. Methylphenidate is actually a very different function. It's actually a rapid or potent dopamine reuptake. So as opposed to dumping it back out, it's just provides a rapid block of the reuptake. And so it builds up dopamine and norepinephrine in the synapse. So it's less euphoric. And you see that when you look at the number of problems caused by methylphenidate as opposed to amphetamines. Methylphenidate is less abusable. It is less prone to negative health outcomes. Well, let's look at the non-stimulants. And again, a couple of these are non-FDA approved, bupropion and modafinil, but there is evidence for them both being effective. Atomoxetine, guanfacine, and clonidine all are FDA approved. Atomoxetine is actually a potent norepinephrine, so it doesn't do much on dopamine. So patients who are overstimulated by dopamine sometimes do okay on the atomoxetine because it's only working on norepinephrine. But it's kind of it's like an SSRI, but it's only working on norepinephrine. So it's a kind of a slower increase reuptake inhibitor for norepinephrine only. Bupropion is a slow dopamine and norepinephrine, so it's a DNRI, so slows the reuptake of dopamine and norepinephrine, which slowly grows in the synapse and helps increase dopamine tone. Modafinil, we don't exactly know. We do think it has some effect on dopamine and some agonism at the receptors and glutamate and GABA effects, but there is evidence that it is helpful for ADHD, but might have a unique mechanism. I do have patients where they can't tolerate any of the other medications, dopaminergic medications, and they seem to tolerate modafinil okay. It seems like it's doing something different in their bodies. And then guanfacine and clonidine are actually both alpha receptor agonists and decrease sympathetic tone. So they're not increasing dopamine, they're actually decreasing sympathetic tone in the end. So they can be used quite differently, oftentimes in combination with stimulants. If stimulants help attention but are overstimulating other aspects of the individual, you can use these guanfacine or clonidine in conjunction, or some people use them at bedtime. The stimulant is helpful during the daytime, but they can't settle down at bedtime. They use one of the guanfacines or clonidines at bedtime to help decrease that sympathetic tone at bedtime. So, really question, if these are increasing norepinephrine or dopamine, are they stimulants as well, even though they're listed as non-stimulants? So if we placed all these medications on this dopamine curve, we can look at, to what degree are these things increasing dopamine? When might you think of the potency of the medication playing a role in someone's dysfunction, dopamine dysfunction? So, again, as we talked about, the amphetamines are really, really potent. It's going to dump out all that dopamine, norepinephrine, serotonin. So it's going to really cause a really significant increase. So if somebody's really low on that curve, amphetamine-based medication might increase them much higher on that curve. Methylphenidate, a little bit less. It's not quite going to be as potent. Atomoxetine, really only norepinephrine. So maybe only somebody mildly low on that curve is going to get up there. Alpha agonists are actually going to pull people back down. So they're looking at people who are over the curve and need to be pulled back down on the curve. I have some patients with combinations of ADHD and anxiety disorders where we use alpha agonists primarily to help them pull back down on that curve. Again, some of those non-FDA medications, bupropion, modafinil, we didn't talk about it, but antipsychotics are dopamine blockers. They're, if somebody's got schizophrenia, aggression, paranoia, it's going to pull them way back down on that dopamine curve. So they are also acting on that dopamine curve, just on the other end of it in a very, very potent fashion. Have stimulant treatments of ADHD been supported by high-quality long-term studies of to showing that they're effective? In short, unfortunately not. When Cochrane reviewed the amphetamines for ADHD, they found that really the subjective effect was very strongly positive. The objective effect was positive, but maybe less than the subjective effect. So still positive, but really, again, think about that euphoria-inducing quality of the amphetamines. They found that the amphetamine subjective effect was really high, the objective effect high, but the subjective effect even higher. So you got to be careful. I talk to my patients about looking at function and not feeling with stimulant medications. You want to make sure you're focusing on whether you're doing better, not whether you're feeling better, because feeling can be tricky with these medications. They also showed that many of the studies had bias and that the duration of the trials was actually quite short. So we do have a sense generally that stimulant medications, amphetamines, can be helpful, but maybe we should, humble ourselves a little bit that some of those studies were not as good as they could be, and that the evidence primarily was short-term evidence rather than long-term evidence. I'm going to skip this. Do stimulant medications pose health risks to appropriately diagnose patients at recommended doses? In short, no. There are studies that found individuals can experience increased blood pressure or heart rate, but it did not significantly affect any of the EKG intervals, PR, QRS, or QTC. They actually found also that when you control for any your pre-existing cardiac conditions status, psychostimulants did not by themselves, or atomoxetine did not increase the risk of MI or sudden cardiac death or stroke. Patients with unstable cardiac conditions, you don't want to use them in. There's also evidence that ER formulations decrease emergency room services, so less prone to adverse effects. I'm going to skip that for the moment and just say that, overall, the risk of dependence and social harm from psychostimulants is there, but it's fairly small. So the percentage in the past year that misuse stimulants, in most age groups is pretty small. That said, in this age group of 18 to 25-year-olds is pretty high. So you really have to be more aware in that age group of how someone's using things as opposed to in general other age groups. Skip that as well. This just shows that there's a relative difference in the social harm, dependence, and physical harm between amphetamines and methylphenidate. This wheel increases as you go up, heroin being the most, alkyl nitrates, ecstasy being lower in this array of substances. Amphetamines was up there with benzodiazepines and tobacco, methylphenidate lower, so lower risk with methylphenidate. Some of the many things you have to look out for when treating with stimulants. So I use the acronym HOPE, so heart, ophthalmologic, psychiatric, and endocrine. If there's significant cardiac problems, you probably want to avoid psychostimulants. Narrow angle glaucoma, it's the only glaucoma that really is a contraindication to stimulants. Untreated hyperthyroidism, pheochromocytoma, anything that's already going to increase blood pressure, heart rate, you want to not use stimulants with. And then certain psychiatric conditions, certainly a history of mania or psychosis, you got to be, with psychosis, I wouldn't use it at all. With mania, there is evidence that somebody's got adequate mood stabilization. You can use low doses cautiously in somebody who's got bipolar disorder and ADHD, which is not actually uncommon. And then certain other medications you don't want to combine. Should I always start patients on long-acting formulations? Not necessarily. It's easier to titrate up on short-acting formulations. If you use a long-acting, you have to say, okay, we'll take this for a month and then take this for next month. In a patient who's high risk, you might want to do that. But in a patient who otherwise is not high risk, is pretty low risk, straight shooter patient, you can get up to figure out what dose they're going to need a lot more quickly if you use a short-acting stimulant as opposed to starting out with a long-acting stimulant. What I usually do is if there's any risk of diversion or misuse, if they're in that age group, if there's a history, I usually would start out with an XR form. But if not, I would usually start out with an IR form of methylphenidate, again, lower risk methylphenidate in the end. Start out with 5 milligrams QAM at noon. Be careful of the BID, SIG, because patients can take it at nighttime, which you don't want them to take it at nighttime. QAM, Q noon, and then increased by 10 milligrams, so up to 10 and 10, 15 and 15, 20 and 20, up to a max dose of 60. Once they find their sweet spot, and usually they go over the curve and say, oh, that was too much, I got to go back to my previous dose, then I convert that to XR. If it's ineffective, then I might use amphetamines, and then I do similarly start 5 milligrams AM and noon, increase by 10 total dose every 5 to 7 days, max dose 40 milligrams, then convert to long acting. Atomoxetine, really, I only try if either of them find the methylphenidate and amphetamines helpful but intolerable. But if they're not tolerable, if the amphetamines and the methylphenidate make things worse, then I might consider guanfacine or clonidine. They might be on the other end of that curve. We may need to pull them back down rather than push them up on the curve. So again, IR and the AM and noon. If you convert that to an XR, you're looking at a longer period of duration. Some people might use an IR early in the morning, or if somebody's got a late night meeting or something like that. I do have patients where I primarily use the XR, and then they have a small number of IR that they refill once every 6 months or something like that, that they're used for kind of late night meetings. Again, these are kind of straight shooter patients where there's no other concerns. So just a quick recap, ADHD treatment in adults should consist of psychoeducation, lifestyle adjustments, CBT or executive function coaching, consideration of medications, not always. And then stimulant medications have a more robust treatment effect, although high quality long-term studies are limited, and stimulant medications are generally safe for most adults with ADHD at recommended treatment doses, while they do warrant monitoring, especially for cardiovascular and psychiatric changes at the end. You can ask for help. You can call OPAL, which is the Oregon Psychiatric Access Line, which will give you, if you have questions about medications or diagnosis, certainly do call. There's psychiatrists there during business hours during the week who can help advise you on your questions. And I will end there.
Great. Many thanks, Dr. Stanley. Thank you for the reminder about OPAL and also for a practical and comprehensive review of this complicated topic. I will just go to a couple quick questions in our last moments. Awesome. There are a couple questions wondering about any relationship between ADHD and autism. Any comments there?
Yes, there is ADHD has higher frequency in patients with autism spectrum disorders, as well as OCD and tic disorders. That's like the big three that often are present in autism spectrum disorders. Not always, but they're highly prevalent. Yeah, autism spectrum disorders are a fascinating thing. It really has to do with the brain not pruning itself very well. So again, the brain starts out with the largest number of neurons it's ever going to have, and then has periods of pruning in kind of weaning down like those effective networks during toddlerhood, during adolescence, onto the 20s, and then for some people later in life as well. But really the autism spectrum disorder doesn't prune very well, so they have a whole bunch of extra junky neurons around there in their brain, which are causing overstimulation. They feel a lot of different things. It's hard for them to tune things out. And sometimes the ADHD medications can be helpful for them.
Great, many thanks. And then we can finish up with some last thoughts here. We had a viewer who makes the comment, as a primary care doctor, I sometimes feel like a pill dispenser. How do you talk to adult patients who come in with ADHD symptoms and are very focused on asking for a stimulant medication? Strategies for communication there.
Yeah, it's a tough discussion. And I think sometimes we do end up trying medications sooner than we'd like. And I unfortunately blame that a little bit on our healthcare system and the availability of other treatments. Other countries, really emphasize those other non-pharmacological treatments very early, and we don't have a system that really substantively supports that. So, I think we do reach for pills a little bit faster, but I don't want us to blame ourselves necessarily for that all the time. I do work strongly with patients in trying to go through from a psychoeducational standpoint, all the different things they can do, and saying that, certainly, if you're not using good sleep hygiene, you're not getting some physical activity, you're using substances, you're not going to actually get benefit out of these medications. One of the things I usually do is very clear, and the evidence says that if you're using cannabis, you're depleting your dopamine stores anyway, so you get nothing to mobilize. So stimulant medications aren't going to work if you're using cannabis. So patients will say, objectively or subjectively that they might feel something, but again, it's feeling and not function. The studies seem to say that function doesn't improve if somebody is using cannabis, even if they're using stimulant medications for ADHD.
Great, thanks so much. That's very helpful. I know the slide that provided information about education and also those resources are something that I'm gonna take up into my practice. So thank you for that.
Yeah. Yeah, there's a website, Attitude, ADD that I listed on there, which is a very patient-friendly website. I find a lot of patients like that, even if they're somebody who's just having inattention for other reasons. It's got lots of, tips and tricks on how to manage attention, but also kind of, if you do have ADHD, how you still have self-esteem, how you can work on other areas of your life that aren't medication-based. It's really a non-medication based intervention to try to help people be more aware of the different things they can do. It's very patient-centered. I like it a lot.
Great. Website ADD Attitude. Thank you.
There you go.
Thanks, Dr. Stanley. So appreciate your teaching today. We'll see you again in the future.